Thanks for sitting down. My name is Brian Walsh, and I'm a writer with Time Magazine. I've been asked to give a brief introduction to this last Big Ideas session on the Body 2.0. I want to thank you first for making it out here on this last day as we wind down what's really been a great and stimulating conference. We have a large panel this morning, so many of whom were gracious enough to step in at the last minute. And they're all much smarter than I am, so I'm going to keep this very brief and get right to them as soon as possible. One recurring theme I've noticed from this forum has been really the importance of connection. Yesterday we heard Deepak Chopra tell us that the secret to happiness was, in essence, connection. Feeling connected to each other and connected to the world. Last night at the evening exchange on global health, we were reminded that when it comes to infectious disease, as we're seeing right now with the H1N1 influenza pandemic, we really are all connected. And of course, the debate over healthcare reform in the U.S. should remind us that we all depend and pay for the health of the nation, and there's no hiding from that fact. That's the case with the body as well. The subtitle for this program was Building a Better Human, but we're not getting into $6 million man territory here, although given the rise in healthcare costs, it would probably be closer to $6 billion now. But to a large extent, that is what we're talking about, technology and the way it can be harnessed to enhance our health by connecting us to the information that we need to diagnose and decode our problems, really to help us see with scans that have greater acuity than any doctor. It can also help fix our healthcare system by empowering patients and by cutting inefficiencies that often come from a lack of information, from seeing our healthcare in isolation. But technology and the limitless connection it enables can harm us as well if we let it control us. But cutting ourselves off from technology isn't the answer, and I think among this audience that would be pretty much impossible anyway. Instead, we have to master it for ourselves and for society instead of being mastered by it. I'm going to start by introducing our first panelist, who's Linda Stone. She spent nearly 20 years as an executive in high-tech companies, including Apple, where she worked on multimedia hardware, software, and publishing, and Microsoft Research, where she worked on virtual communities and online social life, which is a connection as we were talking about. Since retiring from Microsoft in 2002, she's been a writer, a speaker, and a consultant, focusing especially on technology and its effect on our brains. If you've heard of the term continuous partial attention, which many of you are probably practicing right now, you can thank Linda. She'll be speaking on email apnea, on the way our engagement with BlackBerries, iPhones, and laptops can literally take our breath away. So, Linda, please.
Thank you, Brian, and thank you, Michelle. It's great to be here. So, to set the stage for my comments, I'd like to teach you all a diaphragmatic breathing technique. And if you don't want to play along, I promise you I won't notice. But if you do want to play along, it'll be an interesting accompaniment for the talk. So for this particular technique, the exhale is slower than the inhale. And it's important to breathe in and out through your nose, not your mouth. So the specific technique, it's diaphragmatic, so you want to feel an expansion in here. And I'm going to ask you to inhale to the count of 4, and don't do a inhale, nothing like that. This is just gentle. Inhale to 4, hold for 2, and then exhale very slowly to the count of 8. So let's do that a couple times, then I'll start. Inhale to 4, hold for 2, exhale for 8. Inhale for 4, hold for 2, exhale to 8. So that's just a little trick to upregulate your parasympathetic or rest and digest nervous system, something that we're compromising today in the way that we use technology, and that's what I'm going to be talking about. Sometimes we miss the simplest possibilities, the things right in front of us. For example, we look at obesity and other stress-related diseases, and we think it's all about food. I'm going to talk to you about how it might actually be about breathing. I want to talk to you today about something that I call email apnea. You've all heard of sleep apnea. Over 12 million Americans have it. Apnea literally means to take your breath away or without breath. We take it seriously because we know that it contributes to cardiovascular disease, stroke, headaches, weight gain, and a host of other problems, memory problems. So I'm here to talk to you about another kind of apnea, a kind of apnea that I think is quite possibly epidemic and that deserves to be studied, email apnea. So email apnea is the temporary cessation of breath or shallow breathing while doing email, texting, or working at a mobile device. And there are two mechanisms that lead to this. One of them is that when we sit at a computer, we're often shoulders forward, arms forward, chest caved in. How many of you relate to this? A few? When we're texting, if we're standing, BlackBerry, iPhone, it doesn't matter, we often anchor ourselves and we're like this. Familiar? Right? You can't get a full diaphragmatic breath when you do that. In fact, what typically happens is you shallow breathe or breath hold when you're doing that. My journey into email apnea started about 2.5 years ago. Chronic osteomyelitis of the jaw had led to frequent and very serious respiratory infections and also to asthma, something that I hadn't previously had. I started a breathing practice actually at the suggestion of my MD. I would go out for a walk in the morning, come back, sit, do 20 minutes of breathing, and then I would go to my computer to write and do email. And when I started this breathing practice, it was astonishing to me that every time I walked over to the computer, I would notice that I had completely stopped breathing. After a few days, I decided to start observing and interviewing other people and to see how prevalent this might be. And what I discovered over a period of 6 months after interviewing and observing over 200 people was that about 80% of the people that I had observed had what I came to call email apnea. Well, I wanted to know then, what are the consequences of breath holding over time? Just, day after day after day, breath holding. What are the consequences of that? So I called Dr. Margaret Chesney, who then was at NIH, and she and her husband, David Anderson, another NIH researcher, had done some research on breathing and breath holding. It's basically correlated with nearly every stress-related disease. I'll talk more about that. One of the other things I mentioned, one of the mechanisms for email apnea is just physiologically we're not in a position to really breathe. But the other piece of it is emotional. How many of you notice that when you're anticipating something or when you're surprised, you go like that, you have a sharp intake of breath? It's very common. In fact, it's one of the things that's common to all mammals, and Al Lee, who wrote a book called Perfect Breathing, says it's in our DNA, is that with anticipation or surprise, or when we feel threatened or feel fear, what we tend to do is breathe in and hold our breath so that if we are in danger, we can hear more acutely. But when you do this, and then you forget to exhale, it's a problem. And so when we sit at our computers, the posture, the anticipation and surprise, and the screen flooded with emails and the brain flooded with planning, you get the picture. We forget to exhale. Breathing is a cue that our autonomic nervous system uses to regulate parasympathetic and sympathetic function. So sympathetic function is our fight or flight response, and we've heard a lot about that in different sessions with Deepak Chopra, Goldie Hawn. A number of people have talked about that here. Parasympathetic function is rest and digest, and as I talk to you, consider the number of digestive diseases that are on the rise, and the number of people taking these purple pills that I can never remember the name of. Most of the time when we're eating, we are in a sympathetic response. And so how on earth are we going to be able to really assimilate our foods? When we're relaxed, our breathing is slower and deeper. Just my curiosity, nod your head if you're still doing this 4-2-8 thing. How does it feel? Pretty good? So what happens to us when our bodies are upregulated sympathetic state or fight or flight is that we're all prepared to escape from a predator. But in the case of email or texting, the only predator is our inbox. So we sit there flooded with cortisol and noradrenaline and glucose and cholesterol, and we're just trying to clear our inbox. We're not burning off all those resources. So a couple different things happen when we upregulate that sympathetic response. The body becomes more acidic, and all the stress-related diseases related to a more acidic body are on the rise. The kidneys begin to reabsorb sodium, and oxygen, carbon dioxide, and nitric oxide balance is compromised. So breath holding and hyperventilating both disturb our body's balance of oxygen, CO2, and nitric oxide. In fact, there's research going on now that's linking issues with nitric oxide also to obesity. I don't think it's just what we eat, frankly. Our bodies use nitric oxide to fight infections and tumors. Nitric oxide transmits messages between nerve cells. It's associated with the processes of learning, memory, sleeping, feeling pain, depression. It's associated with inflammation. Breathing cues our autonomic nervous system to regulate sympathetic and parasympathetic. And when we sit at computers or work at these mobile devices, our breathing becomes very compromised. The parasympathetic nervous system, further, governs our sense of hunger and satiety. How many of you have noticed that when you're really on the go and you're working a lot at the computer, you don't know whether you're hungry or full? Unless you're breathing, unless you're doing diaphragmatic breathing, your body can't cue you. And so your tendency is to eat more. Parasympathetic is implicated in the relaxation response, healthy organ function. The vagus nerve touches 11 organs and resources them to be able to digest, function, do some important things. Let's see. Email apnea activates fight or flight, so it causes the liver to dump glucose and cholesterol into the blood. Our heart rate increases. As I mentioned before, our sense of satiety is compromised. Our bodies are resourcing for physical activity that historically does go with fight or flight, only we are just sitting there, not burning off these resources, so we're kind of all dressed up, nowhere to go. In the last couple minutes, I'm going to talk to you about what we can do. Breathing, it turns out, is a habit. And if you're an athlete or if you're a musician, you study breathing techniques. So do test pilots. They study different breathing techniques. One of the things that has become clear to me in studying this is that it's very challenging to change your breathing at the computer for the reasons that I talked about. But what you can do is take a breath like this one that I taught you at the beginning, and you can just do that at various points during the day while you're listening to a talk, while you're sitting in your car, when you wake up in the morning, right before a meal. It would absolutely change your sense of hunger and satiety. I find when I sit and breathe for a few minutes before a meal, I tend to eat less. I know when I'm full. I feel more sated. So one of the things is to just build that habit in. There are a variety of different breathing techniques that do upregulate parasympathetic nervous system function. So one of them is this thing that I taught you a minute ago, diaphragmatic breathing, which is not hyperventilating, it's not deep breathing, it's diaphragmatic breathing, like we talked about earlier. Buteyko breathing, developed by a Russian MD, that's another habit that you can develop. Andy Weil actually has a great breathing CD that is worth paying attention to. Some of you probably do martial arts or yoga, and those breathing techniques, also the breathing techniques sometimes associated with continuum or certain Pilates or diatonics exercises can be helpful. And all of this can serve to soothe us and to help our bodies understand and know when we need to be in fight or flight and when we can relax. In February 2008, I wrote a piece for the Huffington Post on this, so if you're interested further, you can look that up. By the end of 2008, some researchers were collecting physiological data. One of them, Dr. Eric Pieper at SFSU, published a study earlier this year on college students texting. He looked at physiological measures like pulse, pulse oximetry, galvanic skin response, heart rate variability. 84% of those college students in this study had what I call email apnea. As I've continued to research the potential impact of email apnea, the relationship of breathing to attention, to emotional and social intelligence, to cognition, and to our ability to regulate our emotions is all there in the research. So here's my wish. My wish is that as individuals, we practice healthier breathing habits when we can. That in schools, we find a way to do 3 10-minute breathing breaks. My hunch is there would be noticeable differences in behavior, performance, attention, and physical health. And finally, I think that we could develop non-invasive technologies that would support us. Do any of you drive a Toyota Prius? Anyone? So have you noticed how there's that display that doesn't say, "You idiot, you're using too much gas," or "slow down"? It's not punitive. It just sits there and you look at it and you see that when you get to work in 24 minutes, you use a lot of gas, and when you get to work in 22 minutes, you use a lot more gas. So when you get to work in 26 minutes, you use a lot less gas than if you take 2 or 3 minutes longer. My friends who drive the Prius tell me that over time, what happens to them is that they want to game the system, that they're very motivated to, well, I can do better than what you think, that's the relationship that they develop. I don't think we need punishment. I don't think we need programs on the computer that say, breathe, get up. I just don't think we respond to that kind of stuff. But something non-invasive that maybe pulls physiological data and gives us ambient information back that allows us to regulate ourselves, that I think would be interesting. So can we come up with non-invasive technologies like this that motivate us to game the system, because the technology is here to stay and breathing is cheap and simple. So what would happen if we actually gave our bodies a break from today's constant fight or flight lifestyle? Thank you.
Thanks very much. Ever since you told me about email apnea, I've noticed my posture is Quasimodo-like when I'm using the BlackBerry, and it's not very healthy. Next, we have Esther Dyson, who's a familiar figure to Aspen audiences, a venture capitalist who has specialized in information technology and sometimes seems to have the ability to predict the future. Among her investments have been Flickr and Delicious, as well as Meetup Inc. and Boxby. Lately, she's turned much of her focus to health and IT. She'll be speaking about the way our increasing ability to track data is influencing our bodies and our minds. Esther.
Thanks. And thank you, Linda. This was a perfect example, to some extent, of what I'm going to talk about. If I had to give this talk a title, I just wrote a few notes this morning. It would be The Quantified Self, the Mystical Power of Information. If I got up here and I started talking about my sex life, you would probably continue breathing normally. It wouldn't be very exciting. Not because it's my sex life, but just in general. People are very happy talking about sex, but narcissism is still, not quite so polite. I'm going to talk to some extent about narcissism today, or perhaps more politely, how we can harness narcissism into something that will make us more healthy. As a girl, I was young and precocious, and I was very concerned about my age. I would always ask other kids how old were they and that kind of thing. Then later, I was very interested in my SAT scores and ultimately my salary. I'm old enough that when I was in my 20s, there was this notion that your salary should match your age in thousands. And yeah, that was really long ago. We'll fast forward to maybe the last 10 years. When I first started looking at the personal computer industry, when it first started to exist, there was this notion that people would use personal computers if they were, this of course is typecasting, women to manage their recipes, if they were men to manage their wine cellars. It didn't quite happen like that. But one interesting thing that did happen was they started using Quicken to manage their money. People got much better at managing their money when they had the information technology to do so. Then they started demanding that information from banks so that they could download it and manipulate it, compare, or match the money they had in their bank account with the money they had in their ledger of debts or their credit cards, whatever. More recently, there are companies you may or may not know. Doppler allows you to manage your travel. You record where you're going. You can share this information with other people and find out when they're going. And, oh, we're both going to be in Aspen next week. Let's meet. Skydeck lets you look at your cell phone records and figure out whom you call the most. Do you call your boyfriend more, or does he call you more? Is it really true that you didn't call your mother more than twice last month? You can look at your own behavior, and again, ultimately, you can compare it to the behavior of other people. Facebook, of course, lets you do amazing things. You can count your friends. There's a couple of different tools that let you look at your Twitter stats. How many people follow you versus how many people do you follow? What's your Twitter ratio? All great examples of narcissism, really interesting stuff, and I've got to believe to some extent they influence people's behavior. Also, we know that our Facebook friendships vary. The fact that you have 1,000 friends, it's really meaningless. You know which 10 are your best friends. 900 of the 1,000 you might or might not recognize if they walked in, but somehow they got your email address, invited you to be a friend, whatever. But still, those numbers somehow matter. Now the same thing is starting to happen with other kinds of information, with health and personal body information. I'm on the board of 23andMe, which lets you look at your own genome. Most of this information is not going to surprise you. I had, as you can imagine, I had my genome done, also 30 family members. Really enjoy looking at how our genomes vary and which sister is most like which other sister. And yes, thank goodness, the identical twins really are identical. But if you have a family history, you probably know that you have a tendency to colon polyps, which I do, both in real life. My dad has them, so do I, and lo and behold, so I do on 23andMe. But this information right now, most of the users of it are benefactors because they put their data into the system. In the long run, they'll be beneficiaries. Polka.com is an interesting startup. It has a couple of medical applications on the iPhone. It also has a daily monitor tool. I've started using it about a week or two ago. Every day, how many hours did you sleep? How much do you weigh? For me, how many minutes did I swim? Et cetera, et cetera, et cetera. And maybe in a year, I'll actually have some interesting charts to look at. But it takes a minute or two, and I like doing it. Patients like me, where ALS patients put in huge amounts of data. They run their own clinical trials. They compare their data to one another's. They console each other. They advise each other. It's a very intense. This is not just a chronic disease. This is with you every day. And so these patients are unusually absorbed in this. But they're an outlier that shows where things are heading. There's something called the Quantified Self blog. Go take a look, by Kevin Kelly and Gary Wolf. There are now quantified self meetups where these quantifiers go meet up and talk to one another, share their measurements, talk about cool tools they've used. There's this whole community that is now small but leading the way. So what does this mean for business? And then ultimately, what does it mean for our health? For business, I think you're going to see some interesting phenomena. I think you're going to see the equivalent of what happened with Quicken in online banking happen also with medical information. Adam Bosworth later on is going to talk about something called healthdatarights.org, which says you have the right to your own data from these institutional sources that create it. There will also be lots, and people like Quest and LabCorp. I wasn't able to get the numbers because I just found out about this talk this morning. But I'm sure you would find that they're doing more and more direct-to-consumer testing. 23andMe, the genome companies, there's going to be more and more companies servicing this demand. Blood pressure monitors, home tests and diagnostics and monitors of all kinds. The number of steps you walk, they're, not velocity, but movement monitors of various kinds. One thing I really loved, you saw Mehmet Oz's simulation, most of you, yesterday. Imagine if you had a tool that would do that kind of simulation for you, but it would also look at your data. And so every Sunday morning when you were breathing calmly and ready for the shock, you could say, based on my behavior last week, how am I going to look when I'm 65? And then you could try and change that, just as you try and change your behavior in response to what your Prius tells you. You would try and change your behavior in response to what that simulation tells you. There's another version, which is what I would call the rest of life chart, which shows not just when you're likely to die, but what shape you will be in until you die. Again, to move that curve up and down, to move the green, healthy part to cover more of your life, and the sick or frail, unhealthy part to be smaller. That's the kind of biofeedback people are going to want, and companies will develop tools for them to do this. So the big health question, of course, is all this monitoring, all this narcissism, all this self-involvement actually going to help improve our health so that we'll have less healthcare cost because we have less need for it, not simply because it's more efficient or the incentives are better or whatever. I believe so. I think there's a huge difference. Putting calorie counts on menus is a start. But imagine if you had a tool that you could point it at your menus, it would sum up how many calories you eat in each day. Again, it's the personal information that has the power, not the general information. Not about them, about those things, but about me. That, I believe, is going to change people's behavior. Second, there's the power of the groups. So it's easy to get all this information. It can be much harder to act on it. You can get an email reminder to take your pills or to breathe for 10 minutes perhaps, but it's much harder to avoid that last donut, take that extra run, having friends online whom you can call on when you need them. If you have an online community of 100 people who are all either rooting for you, another generalization if you're female, or competing with you if you're male, you can go online at any time. At least 5 or 6 of them will be there to encourage you, console you, prod you to do the kind of thing you're doing. It's kind of like Alcoholics Anonymous, but online for you when you need it. There is very little bit of information. Various studies have been done. John Moore at Chilmark showed me a couple this morning, Chilmark Research. I think there's going to be more. I want to end narcissistically with my own little anecdote from the last 2 days. I went and did the body mass thing that General Electric had out in the lobby there. And they told me that my torso was under-muscled. So in the swimming pool this morning and the day before, I did some extra torso strengthening strokes. And I'm watching myself, I'm in the business, but it was a very real response to seeing that. This is a number I could change. I want to change it, and I know how. So Linda had a wish. I, too, have a wish. I wish that we can harness the narcissism and have better health and less health care. Thank you very much.
Thanks very much, Esther. I'm all in favor of narcissism, especially when it has to do with me. Next, we have Dr. Ann Maas, who practices internal medicine here in Aspen. She focuses on early disease detection using advanced lipid screens and biomarkers. She's also an assistant clinical professor at the University of Colorado Medical School and is involved in rural health care reform through the Colorado Medical Society. And she'll be bringing up James Ehrlich as well, and she'll introduce him. Thanks very much. Come on.
Pony show, and I'm actually mainly going to spend a few minutes telling you about what I'm trying to do in my own practice here in Aspen, but I just want to start with a non sequitur, which is a comment about the previous IT session I went to. I think that as a practicing physician, if a national electronic health record could simply reduce medication errors and increase connection between physicians and healthcare systems to prevent duplication of testing in this country, that it would easily pay for itself. I can't tell you, as just someone in private practice, how much money is wasted in my practice on a daily basis by duplicating tests because I can't get data and trying to correct and identify medication errors. So it's my personal feeling. My big idea is that an ounce of high-tech prevention should be worth a pound of traditional cure. And stated a bit differently, early detection of disease is the best predictor of disease prevention. I'll tell you a few of the things that I'm trying to do in my office with my patients to try to really get them to personally buy into their health care and to more personalize their health risk. And then I'm going to turn things over to Jim, who's really a national expert in the field of early detection. We've been hearing all weekend about how our national health system has failed us. It's failed us in terms of cost, it's clearly failed us in terms of prevention, and it's failed us in terms of outcomes. Locally, in offices and hospitals around the country, we're failing patients all the time because people are not complying with medical advice. An extraordinary number of people do not take the medications that I prescribe to them, and they don't do it for a multitude of reasons. They can't afford it, and they won't tell you that. They're afraid of side effects. Some of these side effects are real. Some of these side effects are things they've read about online or that people have told them about. And they're in denial. There's an incredible component of denial that we all have, that this data that I read about in the Framingham study, this data that I've read about on the front page of USA Today, doesn't apply to me. So my challenge is to try, in my smaller world, which is my private practice of medicine, to personalize risk for people so they really get that this data may, in fact, apply to them. And I'll just try to give you a couple of examples of things I've been doing with cardiovascular risk, and then Jim can go into some detail about other things. On Saturday, we heard a beautiful presentation by Rhonda Monroe about her own personal experience with her cardiovascular disease, her heart attack that went unrecognized despite the fact that she was showing up in emergency rooms every day for about a week. And we all know that heart disease goes unrecognized in women in this country, especially young women. I have many women who do not look like they should have cardiovascular disease, who come in my office and we go over their risk profile, and they have a high HDL, which I'm sure most of you would say, well, is protective against heart disease. And they also have a high LDL, and they say, well, my high HDL trumps my high LDL, and I'm okay, Anne, and I'm not. Don't talk to me about statins. Don't talk to me about cardiovascular risk prevention. It doesn't apply to me. In fact, all HDL is not the same. And there are advanced cardiac profiles that, again, Jim will talk about, that can demonstrate that even though you may have a high HDL, your HDL may not be protective, and in fact, you may need statin therapy. Likewise, all LDL is not the same. LDL is made up of at least 7 component particles, some of which are atherogenic, some of which are not. And if I can do some of these advanced cardiac screens on a patient and demonstrate that they have the bad LDL cholesterol, or let's say that they have a high total LDL cholesterol, but they don't have a lot of the bad LDL cholesterol, and associated with that, they have a heart scan that shows 0 calcium, and again, Jim will get into that, which means very low risk of having a cardiac event in the next several years. They may not need statin therapy, so we may be saving the healthcare system a tremendous amount of cost in terms of treating people who may, in fact, not need treatment, as opposed to just treating everybody with a certain cutoff of LDL cholesterol. There are genetic markers of cardiac risk, one of them being a test called KIF6, that can help us identify a subgroup of patients who may be at higher risk of heart disease and may be people who will actually have a better response to statin therapy. So these are just some of the examples. And, people may say, well, Anne, this is really expensive. You can't be doing these tests. In fact, a lot of these tests are not that expensive. They do take some time to go over with patients, but they're not that expensive to do. And they're clearly much less expensive than having to ultimately do bypass surgery on somebody. I'll just end by saying, David Agus, when he talked on Saturday, said we have to figure out ways to do things to push behavior. And my daily frustration is to do what I call, when I sit down with people, get them to turn the light switch. It's not okay, for me to say, well, this is how I'm trying to lead my life. You should be doing it too. Ultimately, somebody has to get up, leave the room, and turn the light switch on themselves and make these changes in their life. And I've come to believe that if I can really increasingly personalize a risk profile for somebody, that I can get them to sign on to do that. And on that note, I'll turn it over to Jim.
Well, thank you very much. Anne illustrates really all the principles here that we're trying to identify disease years or decades before you have a heart attack, do proper risk stratification, improve compliance. Once people have a personal database of understanding what's going on in their own body, they'll improve compliance. And I've been fortunate to have access and experience with more tests and technologies in the early detection of heart disease and various cancers than any other physician in the nation. But I'm going to focus mostly on cardiovascular since we only have a few minutes to give you just sort of a sense of proper risk stratification and why it's so important to identify disease early. So this is from the earliest Chinese text, 2600 BC. Superior doctors prevent the disease, mediocre doctors treat the disease before evident, inferior doctors treat the full-blown disease. Okay? So what's the story here? Well, I guess this is So you see here, this is the way most physicians see their patients. It's like being in the end of the third act of a play, chest pain. Here's a graphic of what's ahead of this child, right? And all the influences, and you have a timeline of developing atherosclerosis. So we need to pull back the curtain several years and identify who's progressing at a much higher rate. How can we slow down this progression and ultimately avert a cardiovascular event? And why is that important? Here's the dismal, humbling statistics. The first manifestation of heart disease in the majority of men and women is irreversible, either a heart attack or sudden death. And then the challenge is who's really at risk. So most people would think Jim Fixx in the years prior to his event or the weeks prior to his event, most doctors would have said you're in good shape. Winston Churchill broke every rule of the book, lived to 93. So we need to be humble about who's really at risk in our practice. And why is that? Because in general, risk factors poorly identify individuals at risk. They do a much better job in populations. So what's available to the clinician? they've got a lot of tools, some of which they're using and some of which are not used too often. Conventional risk factor analysis, what we call Framingham, sophisticated advanced lipid testing that Anne alluded to, non-invasive testing, emerging risk factors like CRP, and many of these biomarkers that we're using. Biomarkers, aspirin resistance, and ways of looking at inflammation and cytokines, and then new imaging modalities. And here's the problem. In the red are from Framingham, thousands of people. These are the people, the cholesterol levels of people who had events. These are cholesterol of people who didn't have events. Look at the overlap. So a cholesterol doesn't very well distinguish who's at risk. So Anne mentioned that LDL is more than one particle. We need to look at that. And so this is just graphically looking at LDL as different particles, IDL and VLDL, and Lp(a) is inherited. And same thing with HDL. So one of our tools in our armamentarium is to do a more accurate cholesterol test, not the 1972 calculation that you're getting generally when you get a cholesterol test. That's highly inaccurate these days, especially in patients on statins. And here's the humbling statistics. I'm just doing one example here. These are women, 65 years and younger, who presented with their first heart attack. None of the women were considered high risk in this study. None of them by conventional risk factor assessment. And 5% were intermediate risk by this risk factor algorithm that we're supposed to use as clinicians. These are the people considered low risk in the weeks prior to their devastating event. 82% of the women were not eligible for anything pharmacologically before their heart attack. And this is another big problem, right? 2.5 million years of evolution. This is the last 50 years, the metabolic syndrome, okay? Metabolic syndrome affected Tim Russert. So Tim Russert visited my center in Washington, D.C., got electron beam tomography 10 years ago. He was at very high risk, had a vascular age of 71 when he was 48. And he was treated by the conventional ways we treat people. And we're now learning about this concept of residual risk, the risk that we physicians leave on the table once we think we have the patient under control, because his LDL was 67 6 weeks before he died. He passed every stress test. So conventional tests and conventional biomarkers don't adequately tell the whole picture and don't allow us to monitor risks very well. So the lessons learned from Tim Russert is that about 75% of the risk is left on the table by we physicians treating patients with, let's say, statin monotherapy. So that's another thing. So what do we try to do? We try, from a cost-effectiveness point of view, is to find out who's at the top of the pyramid, who's at high risk using non-invasive methods, and match the intensity of therapy and the cost to those people at high risk, and leave the rest of us alone with just lifestyle manifestations, lifestyle improvement and public health guidelines that we all should be doing regardless of how low risk we are. So 140 million Americans have average or high cholesterol. 76 million people have high CRP, this inflammatory marker. So there's too much of these things in everybody. So a group of us developed this screening program, national screening program, and the Texas legislature just mandated that insurance has to pay for either a carotid IMT or a coronary calcium quantification. We looked at all sorts of technologies that are available for the early detection of disease. And in general, we decided that instead of waiting for risk factors that don't depict disease well, you do an atherosclerosis imaging test, either a CT scanner looking for coronary calcium or a carotid IMT, and then you treat aggressively or match the intensity of treatment to the amount of risk. So this would be the EBCT scanner, and what we're looking at is a slice of the heart, and the radiologist or cardiologist is looking for evidence of atherosclerosis. And the more plaque you have, the higher your risk, more calcified plaque, as it turns out. And these can be very inexpensive these days. Involves a little bit of radiation. But the ignored organ or tissue, which is the size of 6 tennis courts in our body, is the tissue that regulates and interfaces between risk factors and heart disease, and that's called the endothelium. It's a lining that's huge in the body, And that's the tissue that we should be taking care of. And if we have a Big Mac, for example, that's 6 hours of endothelial dysfunction. If we exercise, it improves for several hours. Here's one example of types of non-invasive tests. This was from Israel that allows us to measure this, 10 minutes on a patient. Here's another test from Houston that allows us to measure endothelial function. And this can motivate patients, once we treat them, to verify they're getting better or to show them that their habits are not very helpful and they're starting to develop early disease. So this looks at temperature rebound, this particular Vendas test. And here's the Big Mac attack. Egg McMuffin, sausage McMuffin, 2 hash browns, 6 hours of poor function of your vessels. Okay, so carotid IMT is a simple thing that physicians can do, can detect disease early. We're looking at thickness here. Okay, evidence of atherosclerosis. We're going to treat these people more aggressively. Why wait for a heart attack when we can find these abnormalities years or decades in advance? Okay, and another technology from Australia we've been happy with that really looks at your blood pressure much more precisely, which is the real blood pressure coming out of your heart. We call that central aortic blood pressure and how stiff your vessels are. And finally, you can't really see this too well, but there are a lot of other biomarkers and blood tests that we can be looking at. So, boy, I don't know how I can advance this. Oh, so here it is, the final slide. You don't want to put your mother in this situation if I haven't convinced you otherwise from a scientific basis. My son, the doctor, wouldn't order calcium scanning, advanced lipid testing, or combination therapy. What was your crime? Okay, so some people need different types of therapies based on these tests. It looks like I got a few minutes here, but I think I'm finished. Thank you.
Thanks very much. I think the ancient Chinese would agree that Anna and Jim are clearly superior doctors by any measure. Next, we have Adam Bosworth. He's the founder and CEO of Kias, which brings together tech and medical IT to help consumers better manage their own health care. Before that, he was vice president of engineering at Google and headed up Google Health, the company's personal health information centralization service. He was also senior vice president of engineering and chief software architect at BA Systems, and like Linda, spent a few years at Microsoft. He'll be speaking on how patients can and will need to take charge of their own health with the help of what he calls consumer healthcare decision support systems. Adam.
First, let me thank the Aspen Institute for inviting me to give this talk. I'm very grateful. I came 2 years ago and was just in awe of the talks I was listening to. When Michelle McMurray asked me to talk, she said I should come up with a big idea. And Michelle knows me well enough to know that if it is a big idea, I'm likely to be passionate about it. So if I seem less than calm or objective about this idea, I apologize ahead of time. We've heard a lot at this conference about what's broken in healthcare. We've heard how there isn't enough evidence about what works, and that's certainly true, and we should be requiring this sharing of population statistics across the various healthcare providers and rewarding those places that are clearly doing the best job and probably penalizing in some way those places that are doing the worst job. But even if we did that, that wouldn't solve a lot of the problems. We've heard, and there's been good books written, that very frequently the standards of care are just not followed by doctors or hospitals. Overtreated wrote this best based on data from the Dartmouth group. But even if that were true, a lot of the treatment that they're describing that should or shouldn't be given is for diseases that should never have been developed in the first place. And if those diseases were never developed, we wouldn't be so exercised about whether there were or were not ACE inhibitors given, because the people wouldn't be getting the heart attacks. We haven't heard as much at this conference about the payment model. There's a great book called Flatlined out about the fact that the way that we pay for medical care is just crazy. We ultimately don't pay based on the value as measured by the overall outcome for the patient. We pay on the complexity and difficulty of the task. Or put differently, I did a rough back-of-the-envelope calculation on how much we pay primary care physicians take-home for the patients they treat, which is what most people think is health care. When most people think health care, they're thinking, I see my doctor, and my doctor figures out what's wrong with me. And I did a rough calculation, and I published it, and everyone said, that can't be right. And I said, show me why it's wrong. And in that calculation, I concluded that at most $23 billion, and probably $19.5 billion were taken home by primary care physicians out of $2.4 trillion in expense. If you do that pie chart, and I was told not to use PowerPoint diagrams, that would be 1% of all health care is actually being taken home by primary care physicians. And this is a particularly bad idea, because if there's anyone who would actually jawbone people to, if you will, turn that light switch on, it's the primary care physicians. And we are paying virtually nothing for the people who are at the front lines. If there's anyone who could stop that slope Jim just showed, it's the primary care physicians. And we're paying nothing for that. We pay 99% of our health care costs to wait till they're at the end of that slope and then treat them, and 1% for the people who could stop them from getting there. And that really is the point of this talk. The consumers need jawboning. They need that light turned on. They need to understand their health. And a key reason that our healthcare costs are out of control are the consumer's lifestyle and ignorance and lack of skin in the game. The patients literally do not know how to be healthy. They have no sense of the implicit costs that they are imposing on everyone, including themselves, by being unhealthy. And they have no incentives to be healthy, short of pain. And it's very late in the day when you wait for someone to have a heart attack or to lose a limb. We have a wave of diabetics who don't really take care of themselves, and that leads to amputations and blindness and renal failure and heart disease and other terrible consequences and costs, and far too many of them don't. They need more than jawboning. They need tools. And I have a dream. I dream of a day when everyone has online access to their health care and their wellness plan. Not their sickness plan, but their health and wellness care plan. Personalized and tailored. I love Dan's talk. Personalized and tailored to their specific health data, their needs, their goals, and their realities. I dream of a day when we don't publish books about how to stay healthy. We publish personalized health and wellness care plans about how to stay healthy, written by the best in the business, experts in their field, but augmented by the feedback and the realities of the online engagement with real patients on these care plans, as we learn what works for whom and what doesn't. I dream of a day when we truly know which care plans actually do work, because we've been able to measure which ones work for whom. I dream of a day when consumers talk about their health score, as today they might talk about their handicap or their FICO score, and they work with trainers to lower it as they do their handicap or perhaps that average mileage per gallon on the Prius. I dream of a day when the doctors are partners in these care plans, not people patients visit when they are sick. And we can, and we will fuel the engine and drive the innovation and payments that will slowly but surely reverse these problems. There is only one thing that is really required to make this a reality, and this is the thing I think is the big idea. As Esther said, I helped found a group called healthdatarights.org. Healthdatarights.org is a site you can visit. It is nothing more. None of us were paid. And it says the following. It says, a declaration of health data rights. In an era when technology allows personal health information to be more easily stored, updated, accessed, and exchanged, the following rights should be self-evident and inalienable. We, the people, have a right to our own health data. We have a right to know the source of each health data element. We have the right to take possession of a complete copy of our individual health data without delay, at minimal or no cost, and if the data exist in computable form, they must be made available in that form. We have the right to share our health data with others as we see fit. These principles express basic human rights as well as essential elements of health care that is participatory, appropriate, and in the interest of each patient. And no law or policy should abridge these rights. When we endorse, as a group, these rights and we support them, the rest will follow. It will follow slowly but surely. As the myriad of people like me or like the other companies Esther mentioned or like Ann and Jim figuring out what's worked, take advantage of this data to start to actually help patients, to help themselves. Those of us all over the world who innovate online can deliver to humans the tools that take their data into account. We can help them best understand their data. We can help them best manage their data. We will connect them with the expertise that is in this room and many, many people like you. You will be able to advise people based on their detailed data. Not the hundreds of patients that you can see in person now, but through the internet, hundreds of thousands or even hundreds of millions of patients can benefit from the kind of advice that was being discussed just before me. We from the IT world, can and will team up with you to make this happen. If we provide incentives for being healthy, e.g., if you're compliant with a regime, not obese, not a smoker, routine exercise, regular preventative care, then the rest will follow very quickly, because people will understand that there is an economic incentive to use these tools. But either way, this will happen. So why do I believe that this is so key? Why do I ask all of you to go and support making health data rights a reality? Well, let's start with the doctors. Shockingly, most doctors don't even have the patient's data electronically. They don't even have a holistic view of what medicines the patients are on, or the images, as was discussed. But the organizations at the source do. Why? Because they wanted to be paid. Every pharmacy knows what prescription they wrote you. Every lab knows what labs they tested you for. Every imaging company knows electronically what the images they delivered you were, because they filed for insurance in every case and they had electronic ways to do it, and they have electronic ways to represent their data. The data is there. We are not lacking data. We are lacking access. And it's a key point. And this data is the data that will empower the consumers to get their data electronically. It was the fuel that will fire the engine of consumer healthcare, because it allows the rise of these online tools you've heard. It allows other humans best equipped to take this data, to figure out what works for whom, and to help them. To deny this data is to deny healthy living to all. We are all in the business of increasing health, and this is the tap that must be turned on. And it cannot be turned on through the doctors alone, because the doctors are not automated. It must be turned on at the source. And that was one of the key points of the healthdataRights.org proclamation. It is not enough to say that your doctor must give you a faxed copy of your lab data. We must say that the Quest Diagnostics and the LabCorps of the world and the hospital labs must give you an electronic copy on demand at the time you get them. And those states, and there are 28 of them, where that is illegal, we need to change the laws. Because why on earth would we tie one arm behind the back of you, the doctors, trying to help the patients, and of the patients trying to help themselves? If you get a prescription, you should be able to demand on-demand electronic transfer. Now, to be fair, many of the pharmacies have actually stepped up in this arena and are delivering data, but many have not. And that is unacceptable. When we do this, there will be many and substantive changes. One of them will be simply what I'll call a revolution deferred. In every place in this country and everywhere else in the world except healthcare, we have seen the internet come in as a tool to take the routine and the stuff that can be systematized and automated and move it out of the hands of the companies into the hands of the consumers. When you flew here, you probably ordered the tickets online. You did not go to a travel agent. When you walked into the counter, you probably had your boarding passes pre-printed. In essence, you had done the work that the other people used to do for you, and you were happy to do it because you had the choice and freedom to decide when you would do this work. And they were happy to have you do it because they were not doing routine work. We do nothing of the sort in healthcare. The routine explanations of how do you manage yourself after discharge, or what should you do before showing up for an appointment, is not automated, systematized, and moved to the internet. And that wastes hundreds of precious hours for every physician. We do not provide the automated tools to help people manage their health when they're not in the doctor's office, and yet most people see a doctor at most 12 minutes a year. That leaves a lot of minutes for them to worry about their health that are unhelped for by us right now in the system. So the revolution deferred. What we've done in health, and what we've done in banking and travel, in buying books and movies and eating, only in healthcare is this revolution deferred. But as we move this data in, that will not be true. The next thing we will see is healthcare anywhere. We will allow people to provide the expertise online. And again, I was listening with fascination to Anna and Jim. That intelligence, that data about biomarkers should be delivered to everybody. It should be something that you can get so easily that even if you're living 5,000 miles from the two of you, I should be able to get at that data, living somewhere down, say, in Venezuela, what have you, online. Because the power of an online system is it doesn't matter where you are. You still have access to it. I believe, and this is what Kies is predicated on, my company, that the most important of these tools to emerge will be care plans. They will be the online tools consumers use to understand what does it mean for them to be healthy, that light switch, that moment of understanding that even though they thought they were in the green, they're not. They're in the yellow or the red, and then the tools to help them get out of the red and into the green. I may be wrong. We'll find out. But there are many, many people like me trying to build tools like this to help consumers get healthy. What we need is the fuel that powers this engine, and that fuel is people's health data, and we need to give people the right to have it. So all of this stems from an incredibly simple idea. Give consumers the right to a copy of their own health data. I'm not saying that the hospitals lose their right. I'm simply saying that consumers have a right to a copy of their data, without impediment, without delay, online, in the place of their choice. Don't talk to me about tethered PHRs, because consumers switch doctors, plans, insurers, and locations all the time. And when they do, that data does not travel with them in a tethered PHR. So they need to be able to copy that data into a place that is of their choice. And when we see that, we will see the rise of online health plans targeted at helping consumers to understand their health. We will see the rise of money flowing to the consumers, the doctors, the nutritionists, and the fitness experts, and the health coaches to support these consumers in their efforts. And this will work because it harnesses the power of the world's intelligence, the world's online delivery, and the world's innovators, both people like me and people like you, innovating on how to be healthy. And it rewards you for doing the right thing. It will not be bottlenecked by how many people in medical school are becoming primary care physicians, because finally we are delivering leverage, where one person can reach tens or hundreds of thousands, not hundreds. It will funnel the money and the talent to what works. When we all support the Declaration of Health Data Rights in deeds, not in words, we will change healthcare. Join me in making the health data rights reality, not a dream. Thank you.
Thank you, Adam. See, narcissism is going to save us all. I can't wait to tell my therapist that. Zoe Baird is the president of the Markle Foundation, a private philanthropy that uses information and communication technologies to address public problems, especially in healthcare and national security. Before that, she was vice president and general counsel for Aetna, a senior visiting scholar at Yale Law School. She has an illustrious record of government service, including 8 years on President Bill Clinton's Foreign Intelligence Advisory Board. She also served in the Technology and Privacy Advisory Committee to the Secretary of Defense. She'll be speaking on how healthcare reform can improve the health of ordinary Americans.
Thank you. It's a pleasure to be with you, and it's wonderful of all of you to give us an audience, so we really appreciate that. The president, in his radio address last week, talked about health care reform as health insurance reform. And I think that's really a very honest statement, because the legislation that's being considered in Congress is about bringing the 47 million uninsured into the health insurance system. It's about providing stability of health insurance coverage as people move from job to job, which they didn't do when we designed an employer-based system. And it's about insurance regulation reform, things like preventing the use of pre-existing condition to deny people coverage. So why is it then that at the time we're talking about health insurance reform, we are also concerned about the growth in costs of health care, and can we afford the biggest obstacle to passing this health insurance reform is the cost of bringing 47 million more Americans into the health insurance system, and the already accelerating costs that we feel we need to control. You're probably all familiar with the data that healthcare in the U.S. is 17% of GDP, or $2.4 trillion. To give you a sense of scale, that's the size of the entire GDP of France or of the UK. And so when we're talking about adding people to a system that's already of that scale, Congress is very rightly concerned about whether we can afford that. Peter Orszag, who's the director of the Office of Management and Budget, has said that to paraphrase him, the largest threat to our economic future is the cost of health care. And if that's true, how can we add 47 million more people, or what are we doing to control this growth of costs if it's such a threat to our economic future? And the reason he says that is that 40% of healthcare spending is done by the government, so it adds to the federal deficit. Businesses are uncompetitive globally because of the carrying the costs of healthcare. Individuals who are trying to start small businesses or support their families can't afford the rising premiums and the costs of healthcare, and so people are foregoing healthcare. And I'd like to suggest that the only way we're going to be able to achieve either adding people to the health insurance rolls, the 47 million, or controlling the growth in costs in healthcare, is to actually target improving the health of Americans.
that our debate should really be focused on how can we improve Americans' health, and through that we'll be able to slow the growth of costs and enable us to afford to add people to the rolls. We know that 75% of healthcare costs are for chronic conditions, and we know that 70% of deaths are from chronic conditions, those chronic conditions being diabetes, heart disease and stroke, asthma, and cancer. And we also know that 50% of Americans suffer from a chronic condition. So if we can focus on chronic disease, we have a real possibility of identifying health targets to improve the health of Americans. We also know how to address these diseases, and you've heard some wonderful examples today, but this is not a mystery to us. We just don't apply it as a country. So Kaiser, Colorado, right here, undertook a cardiac care effort. They looked at the fact that after a first heart attack, 2 years later, 50% of the people who'd been put on beta blockers were no longer on beta blockers. And we actually know this is a national average. So you've had a heart attack, you've had a potentially catastrophic event, and still 2 years later you're not taking your beta blockers. And in the country as a whole, we know that 20% of those who've had a first heart attack are still alive 10 years later, only 20%. So Kaiser took this problem on and began using information technology and other very straightforward tools of communications between patients and the pharmacists. And they were able to reverse this so that 8 years after someone had a heart attack, 80% were still alive. So if you were under, an average American would be 3 times more likely to be dead 8 years later than someone who was under the care of Kaiser, Colorado. We know how to do these things. We know that people who have knee problems, in most cases, can be cared for with physical therapy and put back on track and avoid the complications of knee surgery. But the old knowledge is that you need surgery, and so most doctors still refer people who are having problems with their knees to a surgeon, and surgeons do surgery. So you wind up with both a more expensive procedure, but a reduced, an increased possibility of complications and obviously an increased cost. It takes 15 years on average to get new clinical breakthroughs into everyday medical practice in this country. These are all things that are very straightforward and can be addressed if our objectives are health objectives. And so I'd like to leave you with the thought that our healthcare reform debate should really be about improving the health of Americans, and that the President and our Secretary of HHS and all of us in this room who are concerned about health care should set very concrete health improvement objectives. And we can do this. We can cut the racial gap in diabetes care, for example, by 50% in 4 years and substantially improve the quality of people's health as well as reduce costs. We can prevent 1 million heart attacks and strokes in the next 4 years if we set about doing that, because we know what it takes. We can reduce medical errors by 50%. We can use information technology. We already digitize all our records of medications people are on. We could simply require a physician to check in prescribing a new medication what the individual is already on and whether there are any drug interactions. These are things that we can do if we have very concrete health improvement goals. And I'd like to suggest that it's only by doing these things that we're going to be able to afford to insure 47 million more Americans and stop the extraordinary growth of health care costs in the country. Thank you.
Thank you very much. We've had an excellent panel, and thank everyone for taking the time to join and everyone else for taking the time to be here and listen to it. We're getting near the end, and I know some of our panelists and moderator has a plane to catch, so just going to have a few quick thoughts. What we found here is that really until recently our bodies, these extraordinary machines, were mysteries to us. and to doctors as well. And that's changed really in recent decades. And thanks to diagnostic technology that we heard about today, we can know what's wrong with us. We can predict what's wrong with us. We have information that truly is life-saving. But that needs to go beyond that. We need to not just have that information. We need to have it available to us. We need to have it available to everyone. It's really a shame, I think, right now that a lot of us probably know more about how we use our cell phones than we do about the information of our own bodies. And as we can see from what Adam was talking about and what Esther was talking about, there are new opportunities. There is an IT revolution that's been deferred, but I think it is on its way that could really revolutionize all that. And as Zoe was just saying, it's something we need to do. We as a society, we as a country, we've heard this over and over again this weekend, can't afford to keep kicking this problem down the curb. But I'm feeling more confident than I did when I got here that we really are getting close to finding an answer for that. Thank you very much.